In this video, I will show you how to insert an oropharyngeal airway in a patient who may require extra support for their airway. The reason why I might want to insert an oropharyngeal airway is, again, in a patient whose respiratory status might be compromised because of their airway, because their level of consciousness is, for example, decreased. There are a lot of secretions, and we are afraid that the tongue might roll back to the posterior pharynx and actually obtrude the airway. So to do this procedure, I will need my oropharyngeal airway, I will need a water-soluble lubricant, and my patient. So again, I have assessed my patient, I have identified my patient, and went through ABCDs to make sure that this patient actually requires this airway. And then I have chosen the correct type. Because in theory, I have two choices for this patient. I could put in a nasopharyngeal airway or an oropharyngeal airway. And why would I choose one over the other is because the oropharyngeal airway stimulates the gag reflex in the patient. So if this patient is somewhat alert and conscious, I cannot insert this airway because this can actually cause them to vomit. So what I would do first is I would actually check if the patient has a gag reflex. I could just take a tongue compressor and check for gag reflex by just putting a tongue compressor in their mouth. So why would I choose an oropharyngeal airway over a nasopharyngeal airway? Each of them has their own uses and benefits. For example, a nasopharyngeal airway does not stimulate a patient's gag reflex, so I can insert it on a patient who is semi-conscious or even conscious. The reason to insert this airway may be to preserve the integrity of the airway, but it could also be used for frequent nasopharyngeal suctioning. So for example, a patient who is actually conscious but who's requiring a lot of suctioning, and I don't want to damage the mucosa, and I don't want my patient to be in a lot of distress when I'm inserting the tube for suctioning, that could be an option. Another reason to insert an nasopharyngeal airway could be by request of the physician if this patient requires a bronchoscopy and it's really hard to advance the bronchoscope in the nostrils. So the oropharyngeal airway, it's a rigid airway and it is inserted into the mouth instead of the nose. And the difference between this airway and the nasopharyngeal airway is that it's actually quite a bit larger. It's hard, it's plastic. It prevents the displacement of the tongue in the mouth. But it elicits a gag response in a patient. So a patient who is conscious should not receive this airway because it may actually cause them to gag or to vomit and, change even their cardiovascular status. So that is not a good choice for those patients. If the patient is in respiratory distress because their airway is compromised and they are unconscious, this airway is a good choice because it's very easy and fast to insert, and you can successfully ventilate the patient with an ambu bag through this airway. So this is what we're going to do. First things first, I need to measure my oropharyngeal airway to make sure that it's the right size. The procedure is clean. So this procedure is clean. It does not have to be sterile, even though they come in a sterile packaging. What I'm going to do is I'm going to take this airway and I will measure it first. For oropharyngeal airways, we measure from the tip of the lips to the angle of the jaw, which is the bone that is here, the protrusion of the bone. So I'm going to put it to the tip of the lips, to the angle of the jaw, and this seems to be the right size for my patient. What I'm going to do next is I'm going to double check that the patient doesn't have a gag reflex. So what I can do is I can take a tongue depressor and gently stimulate the top of the patient's mouth to make sure that the patient does not gag. So that's good. What I'm going to do next is I'm going to open the patient's mouth, and I will double check that I don't see any visible obstructions now and that the mouth is not full of secretions, because the reason why we're inserting these airways is often because the tongue is obstructing the airway or because there are a lot of secretions that we cannot get rid of right away. So there are no secretions. If there were secretions, I could use a Yonker suction to gently suction the secretions before I insert the airway. Now that I'm ready, I will take the water-soluble lubricant, generously apply it to the airway, and start inserting. So the insertion happens tip up, And I will have to push the patient's head up and open their mouth at the same time as I'm inserting this airway tip up. And I'm aiming for the patient's uvula. Okay, so once the phalange of the airway is parallel with the patient's nose, and I can see that it's resting on top of the patient's tongue, I will invert this piece, and it will actually physiologically displace the tongue and make sure that the tongue is under the oral airway. So then I will check to make sure the placement is correct. I can see that the tongue is being held by my airway. I see that there are no new secretions, and I can try ventilating to make sure that there are no obstructions anywhere else. So I can take my ambu bag, I make sure that it's plugged into oxygen, wait for this to inflate, and I can try ventilating the patient. And observe for the chest rising. So I observe the chest rising. It's very easy to ventilate, and I don't feel any obstructions.